Hello everyone, and welcome to another stream of Advanced Pathophysiology. Today we'll be talking about Chapter 26, the alterations of the male reproductive system. We will be discussing the entirety of this chapter, mostly because I do not wish to stop at the hormone levels as the required reading, so we'll just jump right in. With that being said, alterations of the reproductive system span a wide range of concerns, from delayed sexual development and suboptimal sexual performance to structural and functional abnormalities. Many common male reproductive disorders carry potential serious physiologic and psychologic consequences. Sexual or reproductive dysfunction, such as impotence or infertility, can dramatically affect self concept, relationships, and overall quality of life. Conversely, organic and psychosocial problems, such as alcoholism, depression, situational stressors, chronic illness, and medications, all can affect sexual performance and fertility and may be risk factors for the development of some typical and types of reproductive tract cancers. Prostate cancer is the second leading cause of cancer death in men and is the most frequently diagnosed cancer in men, aside from skin cancer. About 6 in 10 cases of prostate cancer are diagnosed in men 65 years or older. It is rare before age 40. Incidence rates for prostate cancer changed substantially between the 1980s and the 1990s and has since fluctuated widely from year to year, in large part reflecting changes in prostate cancer screening with the prostate-specific antigen, or PSA, blood test. The decline in rates since 2000 has accelerated in recent years, likely because of the recommendation against routine PSA screenings beginning in 2008. From 2009 to 2013, the rate decreased by about 8% per year. Diagnosis and treatment of male reproductive system disorders are, similarly like female reproductive system disorders, complicated because of the stigma and symbolism associated with the reproductive organs and the emotional, latent beliefs and behaviors related to reproductive health. Treatment and diagnosis for related problems may be delayed, mostly due to embarrassment, guilt, fear, and denial. So, what kind of alterations of sexual maturations do we see? The process of sexual maturation, or puberty, is marked by the development of secondary sexual characteristics, rapid growth, and ultimately, the ability to reproduce. A variety of congenital and endocrine disorders can disrupt the timing of puberty or sexual maturation. These disorders may cause puberty to occur too late or too early. Both types involve a disrupted onset of sex hormones production by the gonads, while the average age of pubertal onset appears to be decreasing. For girls, the age of pubertal onset has remained essentially unchanged for boys. So, speaking specifically to delayed puberty, about 3% of children in North America experience delayed development of secondary sex characteristics. Normally, boys tend to mature later than girls, around the age 14 to 14 and a half years of age. In boys, the first sign is enlargement of the testes and thinning of the scrotal skin. Puberty is considered delayed if there are no clinical signs of puberty by the age of 14. Boys especially tend to be embarrassed by sexual immaturity. Therefore, early diagnosis and treatment are recommended, as well as reassurance for boys as well as for girls. In 95% of cases, delayed puberty is a physiologic delay. That is, hormonal levels are normal and the hypothalamic pituitary gonadal axis is intact. However, maturation is occurring slowly. This constitutional delay tends to be familial and is more common in boys than in girls. Physiologic delay is difficult to distinguish from isolated gonadotropin deficiency and is usually diagnosed retrospectively once pubertal progression is complete. Delayed puberty also may be related to consequences of any chronic condition that delays bone aging, such as lung disease, renal failure, and cystic fibrosis. Many clinicians recommend intervention in physiologic cases of delayed puberty to reduce the psychologic effects often associated with delayed puberty. So the following box is a good spot to hit pause so you can read over all the causes of delayed or absent puberty. So if it's a chronic or systemic condition, or if it's related to the hypogonadotropic hypogonadism, or if it's a disordered puberty. The other 5% of cases of delayed puberty are caused by the disruption of the HPG axis of various etiologies. Human gonadal function is partially controlled by the luteinizing hormone and follicle stimulating hormone, so LH and FSH respectively, the release of which is regulated by the pulsatile secretion of hypothalamic gonadotropin releasing hormone, or GnRH. Most recently, the G protein coupled receptor 54, or GPR54, has been identified as the gatekeeper gene for activation of the GnRH axis based on loss of function studies, both in mice and in humans. GPR54 is required for the normal function of this axis, and data suggests that the ligand kisspeptin-1 acts by stimulating neurons expressing gonadotropin release hormone. The mechanism of childhood inhibition of GnRH release and activation are poorly understood, but appear to involve a feedback inhibition by sex steroids and presumably other central nervous systems pathways. Given the myriad etiologies contributing to the occurrence of delayed puberty, a thorough evaluation should be conducted that includes a physical examination and medical and family history. Such as evaluation should specifically target known contributors to delayed puberty. Lab workup generally consists of X-ray studies for determination of bone age, measurement of the thyroid function, and serum levels of prolactin and adrenal and gonadal steroids. Radioimmunoassays of plasma gonadotropins, and screening for systemic disorders. Adolescents with a high gonadotropin level require a karyotype to rule out genetic causes, and those with a low level may need skull imaging or an MRI to rule out if the pituitary or other CNS infiltrate or tumor may be the causative factor. Although several genes involved in the HPG maturation cascade have been characterized from familial or sporadic cases of primitive isolated hypogonadotropin hypogonadism, many genes regulating puberty onset remain undetermined. Treatment of delayed puberty depends on the cause. The goal of treatment is the development of secondary sex characteristics and fertility when possible. Insufficient sex hormone secretion can be corrected by hormone replacement therapy, such as testosterone for boys. Idiopathic hypogonadotropin hypogonadism is treated with a synthetic GnRH or sex hormone administration, or a combination of both, and may be required lifelong. Bringing us to a precocious puberty. Precocious puberty is a rare event in boys, affecting less than 1 in 50,000. Precocious puberty in boys has been redefined as sexual maturation before the age of 9. One study has noted observed mean ages of beginning male genital and pubic hair growth and early testicular volumes tending towards younger ages than earlier studies have suggested, although this seems to be dependent on race and ethnicity. For instance, Black boys are showing significantly earlier mean ages of stages 2 to 4 genital development and stages 2 to 4 pubic hair than white or Hispanic boys. All cases of precocious puberty require thorough evaluation. Precocious puberty may be partial, complete, or mixed types and can be further categorized into central and peripheral. So there's a couple of boxes here that will explain those in further detail. Central precocious puberty is a GnRH dependent and occurs when the HPG axis is working normally but prematurely. It mimics a physiologic pubertal development, although at an inappropriate chronological age, so before 8 years in girls and 9 years in boys. Besides the premature development of secondary sex characteristics, precocity causes premature closure of the epiphysis of long bones, which ends up resulting in a shorter stature. Central precocious puberty results from failure of central inhibition of the GnRH pulse generator. The diagnosis of central precocious puberty is one of exclusion. Because of the possibility of central nervous system lesions, children with presumed central precocious puberty require long-term surveillance. Peripheral puberty is GnRH independent and develops when sex hormones are produced by some mechanisms other than stimulation by the gonadotropins. Sex steroid-producing tumors, such as gonadal tumors, testotoxicosis, and exposure to exogenous sex steroids are some of the causes. So again, here's a good spot to hit pause so you can review the primary forms of precocious puberty, whether it's complete, partial, or mixed. And then in the following box, we have causes of precocious puberty, whether it's central or peripheral. Let's see if we can fit that all into one spot. There we go. Complete precocious puberty refers to the onset of, and progression of pubertal features. Partial precocious puberty is the partial development of appropriate secondary sexual characteristics alone or in a combination. Premature pubarch tends to occur between the ages of 5 and 8. The premature pubarch is usually the consequence of an early increase in the adrenal androgens that leads to an early growth of pubic hair and possibly a transient acceleration in growth and bone maturation that has no significant effect on timing of puberty or final height. The diagnosis and cause of premature development are often obvious. A thorough history and physical exam is done to determine the velocity of the process and to rule out life-threatening CNS or adrenal neoplasms. Family occurrence helps exclude tumors. Children with precocious puberty also have a tendency toward obesity. In addition, excess body weight early in life can actually influence growth patterns. There's evidence that suggests that excess adiposity during childhood influences growth patterns and pubertal development. Treatment for all forms of precocious puberty include identifying and removing the underlying causes, or administering appropriate hormones. In many cases, precocious puberty can be reversed. Management goals, including diagnosing and treating intracranial disease, arresting maturation until early teen years, and maximizing eventual adult height, reducing emotional problems, and providing contraception if necessary. The most common form, central precocious puberty, is usually treated with potent GnRH agonist analogs, which induce reversible selective suppression of the HPG axis. Treatment does not seem to affect body composition or increase obesity in children with central precocious puberty. Because many of these children are obese, and childhood obesity is predictive of morbidity in adolescence and adulthood, it is important for clinicians to include assessment and management of obesity as part of the treatment for central precocious puberty. Mixed precocious puberty, such as the feminization of a boy, causes the child to develop some secondary sexual characteristics of the opposite sex. This condition is usually evident at birth and is rare in older children. So again, here you see different causes of mixed precocious puberty. A good spot to hit pause so you can see the difference between female and male. So, disorders of the male reproductive system, especially if we're talking about disorders of the urethra. Urethritis and urethral strictures are common disorders of the male urethra. Urethral carcinoma occurs in men older than the age of 60, but it is an extremely rare form of cancer. So, speaking about urethritis, urethritis is an inflammatory process of the urethra without concurrent bladder infection that is usually, but not always, caused by a sexually transmitted microorganism. Biologic agents associated with infectious urethritis in males include Neisseria gonorrhea and Chlamydia trachomatis, Uroplasma urolithecum, and other less common mycobacteria, parasites, and viruses, usually the Trichomonas vaginalis and herpes simplex virus. Infectious urethritis caused by gonorrhea often is called gonococcal urethritis. Infection caused by other microorganisms is called non-gonococcal urethritis. Non-sexual origins of urethritis include inflammation or infection as a result of urologic procedures, insertion of foreign bodies into the urethra, anatomic abnormalities, or trauma. Non-infectious urethritis is rare and is associated with the ingestion of wood alcohol, ethyl alcohol, or turpentine. It is seen also with Reiter syndrome, which involves a number of mucocutaneous lesions. Symptoms of urethritis include urethral tingling, itching or burning sensation on urination, and urinary frequency and urgency. The individual may note a purulent or clear mucus-like discharge from the urethra. Nucleic acid detection amplification tests allow easy detection of N-gonorrhea and trachomatis in the first void urine. Treatment consists of appropriate antibiotic therapy for infectious urethritis and avoidance of future chemical or mechanical irritation. That leads us to the urethral stricture. Urethral stricture is a fibrotic narrowing of the urethra caused by scarring. The scar may be congenital, but can be present at any age and have a wide range of etiologic factors, including untreated urethral infection, trauma, and urologic instrumentation. It can present at any age and has a wide range of etiologic factors, including infection, trauma, and instrumentation. Large catheters and instruments caused internal trauma and ischemia, whereas external trauma, such as a pelvic fracture, can partially or completely sever the urethra and cause severe and complex strictures. In addition, a report has concluded that stricture may occur decades after initial hypospadias surgery. Urethral carcinoma is a less common cause of a urethral stricture. Prostatitis, an infection secondary to urinary stasis, are common complications. Severe and prolonged obstruction can result in hydronephrosis and renal failure. In addition, chronic, severe strictures may lead to urethral fistula and periurethral abscesses. The clinical manifestations of urethral stricture are caused by bladder outlet obstruction. Urethral stricture often manifests itself as lower urinary tract symptoms or urinary tract infections with significant impairment in the quality of life. The primary symptom is diminished force and caliber of the urinary stream. Other symptoms include urinary frequency and hesitancy, a mild dysuria, double urine stream or spraying, and a post-void dribbling. Symptoms of acute urinary retention may occur in the absence of infection or urinary obstruction. Induration at the stricture site may be palpable. Tender enlarged masses along the urethra usually indicate a periurethral abscesses. Urethral stricture often manifests itself as lower urinary tract symptoms or urinary tract infections with significant impairment in the quality of life. Urethral stricture is diagnosed on the basis of history, physical examination, urinary flow rates, voiding cytourethograms, and urothroscopy. Biopsy can confirm carcinomas. Treatment is usually surgical and may involve a urethral dilation, urethrotomy, or a variety of open surgical techniques. The choice of surgical intervention depends on the age of the individual and the severity of the problem. Strictures may reoccur up to 1 year after treatment. Follow-up is necessary during this time. Urinary flow measurements and urethrogram help determine the extent of residual obstruction. So that brings us to disorders of the penis, phimosis and paraphimosis. Phimosis and paraphimosis are disorders in which the foreskin is too tight to be moved easily over the gland's penis. Phimosis is a condition in which the foreskin cannot be retracted back over the glands, whereas paraphimosis is the opposite. The foreskin is retracted and cannot move forward or reduced to cover the glands. Both conditions can cause penile pathologic conditions. So here we're taking a look at picture 1 and 2, phimosis and paraphimosis. If you're unfamiliar, pause and review. The inability to retract the foreskin is normal in infancy and is caused by congenital adhesions. During the first 3 years of life, these adhesions separate naturally with penile erections and are not indicated for circumcision. Although most cases occur in uncircumcised males, stenosis and resultant phimosis can occur in males with excessive skin remaining after circumcision. Phimosis can occur at any age and is caused most commonly due to poor hygiene and chronic infection. Chronic Balanitis or inflammation of the glands and prepuce predisposes older diabetic men to phimosis. It rarely occurs with normal foreskin. Edema, erythema, and tenderness of the prepuce and purulent discharge are usually the reason for seeking treatment. Inability to retract the foreskin is a less common complaint. Circumcision, if needed, is performed after infection has been eradicated. Complications of phimosis include inflammation of the glands, or prepuce, and paraphimosis. There is a higher incidence in penile carcinoma in uncircumcised males, which is associated with morbidity and mortality. But chronic infection, most likely the HPV or human papilloma virus, is usually the underlying factor in such cases. HPV infection can result in a spectrum of genitourinary manifestations, ranging from genital warts to cancers. Roughly 40% of invasive penile carcinomas are attributable to HPV alone. Paraphimosis, in which the foreskin is retracted, can constrict the penis, causing edema over the glands. If edema is such that the foreskin cannot be reduced manually, surgery must be performed to prevent necrosis of the glands caused by constricted blood vessels. Severe paraphimosis is a surgical emergency, and phimosis may require immediate release if there is urinary obstruction. That brings us to the Peyronie disease. Peyronie disease. Peyronie disease, also known as Bent-Neel syndrome, is a fibrotic condition of the tunica albuginea of the penis, resulting in a varying degree of curvature and sexual dysfunction. It is an underdiagnosed condition, with prevalence in the male population as high as 9%. Peyronie disease develops slowly and is characterized by tough, fibrous thickening of the fascia and the erectile tissue of the corpora cavernosa. A dense fibrous plaque is usually palpable on the dorsum of the penile shaft. The problem usually affects middle-aged men and is associated with painful erection, painful intercourse, and poor erection distal to the involved area. In some cases, impotence or unsatisfactory penetration occurs. There is no pain when the penis is flaccid. So here you're taking a look at a picture of Peyronie disease. Although the exact cause is unknown, A local vasculitis-like inflammatory reaction occurs, and decreased tissue oxygenation results in fibrosis and calcification. Peyronie disease is associated with dupuytrenal contracture, diabetes, tendency to develop keloids, and, in rare cases, use of beta blocker medications. There is no definitive treatment for Peyronie disease. Spontaneous remission occurs in as many as 50% of cases. Treatment with pharmacologic therapies, including colchicine, aminobenzoate potassium, L-carnitine, and liposomal superoxide dismutase. Men suffering with Peyronie disease who have significant penile deformity, precluding successful coitus, can be appraised for surgical correction. In men with adequate erectile dysfunction, tunical plication or incision and partial excision, or both, and grafting can be offered, depending on the degree of curvature or the presence of destabilizing deformity, or both. Surgery is considered the gold standard and includes the measures mentioned in the previous sentence, in addition to penile prosthesis-related procedures. That brings us to priapism. Priapism is an uncommon condition of prolonged penile erection and is defined as a persistent and painful erection lasting longer than 4 hours without sexual stimulation. Priapism is idiopathic in 60% of cases. However, the remaining 40% of cases are associated with a spinal cord trauma, sickle cell disease, leukemia, pelvic tumors or infections, or penile trauma. Priapism also has been associated with cocaine use. Intracavernous injection therapy for impotence seems to be the most common cause. Prolonged sexual stimulation often is associated with initial development of the idiopathic type. The two corpora cavernosa within the erect penis are filled with blood and are tender to palpation. Neither the corpus spongiosum nor the glans is engorged. The vascular congestion is thought to be associated with venous obstruction. If the erection remains over a period of days, edema and fibrous development leading to erectile dysfunction or impotence. So here you're taking a look at a picture of priapism. Priapism is a urologic emergency. Treatment within hours is effective and prevents impotence. Conservative approaches, including iced saline enemas, ketamine administration, and spinal anesthesia. Needle aspiration of blood from the corpus through the dorsal glands is not often effective and is followed by catheterization and pressure dressing to maintain decompression. More aggressive surgical treatments include the creation of vascular shunts to maintain blood flow. Erectile dysfunction results in up to 50% of prolonged cases. Balanitis. Balanitis is an inflammation of the glans penis and usually occurs in conjunction with prostatitis, an inflammation of the prepuce. It is associated with poor hygiene and phimosis. The accumulation under the foreskin of glandular secretions, sloughed epithelial cells, and a Mycobacterium smegmatis can irritate the glands directly or lead to infection. Skin disorders and candidiasis must be differentiated from inflammation resulting from poor hygiene practices. Balanitis is seen most commonly in men with poorly controlled diabetes and candidiasis. Antimicrobials are used to treat infection. Circumcision can prevent recurrences and can be considered after the inflammation has subsided. So here you're taking a look at a picture of balanitis. Penile cancer. In the United States, carcinoma of the penis is rare and affects about 1 in 100,000. The American Cancer Society estimates for penile cancer in the U.S. for 2017 are approximately 2,120 cases, and about 360 deaths. Although rare in North America and Europe, where it amounts for 0.2% of cancers and 0.1% of cancer death in men, penile cancer may account up to 10% of cancers in African American and South American men. In the United States, about 4 out of 5 cases of this In the United States, about 4 out of 5 cases of the disease are diagnosed in men older than the age of 55. Major risk factors include infection with HPV, smoking, and psoriasis treated with a combination involved the drug psoralen and ultraviolet light. Men circumcised at birth have less than half the chance of getting penile cancer than those who are not. Penile cancer is more common in men with phimosis and those with acquired immunodeficiency syndrome. About 2/3 of men with penile cancer are diagnosed at more than 65 years of age. Before the development of penile cancer, signs of pre-malignant cancer or epidermal cancer in situ are present. These include thick white plaque that typically involves the meatus, red inflamed areas of Paget disease, red velvety ulceration lesions of erythroplasia, of Queyrat that usually involve the glands, large invasive scaly growths of Buschke-Loewenstein tumor, red plaque with incrustations of bone disease, and in situ carcinoma that generally affects the penile shaft. Men with leukoplakia or erythroplasia of Queyrat may have concurrent invasive penile carcinoma. Pain and bleeding are lead signs of penile cancer. Condylomata caused by HPV may be involved in the development of precancerous lesions. At times, the penis might be the site of metastatic spread of solid tumors from the bladder, prostate, rectum, or kidney. Early squamous cell carcinoma and premalignant epidermal lesions are easily treated, but are often ignored. Delays in seeking treatment are attributed to denial, embarrassment, failure to detect lesions under the phimotic foreskin, fear, guilt, and ignorance. Penile cancer is mostly squamous cell carcinoma, which usually begins as a small, fat, ulcerative, or papillary lesion on the glands, or foreskin, that grows to involve the entire penile shaft. Extensive lesions are associated with metastases and poor prognosis. These lesions are not as painful as the amount of tissue involved would seem to indicate. The regional femoral and iliac nodes are common metastatic sites. Rarely the urethra and bladder are involved. Weight loss, fatigue, and malaise accompany chronic suppurative lesions. Untreated progressive disease causes death within 2 years. So here you're taking a look at penile cancer, the squamous cell carcinoma involving the glands of the penis. The specific diagnosis is made by biopsy after examination to document the location, size, and fixation of the lesion. After a positive biopsy, the extent of cancer spread is determined by imaging tests, such as an ultrasound, a CAT scan, and MRI. Fine needle aspiration of lymph tissue confirms the absence or presence of regional adenopathy. About 30% of penile cancers spread to lymph nodes before diagnosis. Distant metastases occur in less than 10% of cases and may involve the lung, liver, bone, or brain. The following stages are used for penile cancer: stage 0, 1, 2, 3, and 4. Penile carcinoma is primarily managed with surgery. Newer innovative surgical techniques can preserve as much penile tissue as possible without compromising cancer control. For invasive penile carcinoma, complete excision, leaving adequate tumor-free margin, is the goal. A simple circumcision may be sufficient for localized lesions of the prepuce. If the primary site is the glans and the distal shaft, removal of the penis may be necessary. Although conventional radical surgery continues to be an effective approach, the emasculating nature of the treatment has serious psychologic and sexual consequences. Recent studies have challenged the conventional belief that a 2 centimeter margin was required for adequate cancer control. Newer, innovative surgical techniques can preserve as much penile tissue and functional integrity as possible without compromising cancer control. Inguinal lymph nodes also are removed if metastasis to these structures is known or suspected. Palliative treatment with radiation or chemotherapy may be used when the disease is inoperable and bulky inguinal metastasis has occurred. Options for, Options for individuals with carcinoma in situ include local excision, radiation, laser surgery, cryosurgery, chemosurgery, and chemotherapy with a topical 5-fluorouracil. Differentiation, tumor stage, and age influence prognosis. For cancers that are still confined to the penis, so stage 1 and 2, the 5-year relative survival rate is about 85%. If the cancer has spread to nearby tissues or lymph nodes, so stages 3 and 4, the 5-year relative survival rate is approximately 59%. Disorders of the scrotum, testes, and epididymis. Starting off with disorders of the scrotum. Men may seek treatment for painful or painless scrotal masses. Masses may be serious, whether it's cancer or torsion, or benign, hydrocele or a cyst, and may require immediate surgical intervention or allow for careful observation. Varicocele, hydrocele, and spermatocele are common intrascrotal disorders. Varicocele is an abnormal dilation of the vein within the spermatic cord and is classically described as a bag of worms. Most 95% occur on the left side and may be painful or tender. Varicocele occurs in 10% of males and is seen most often after puberty. Sudden development of varicocele in an older man is a late sign of renal tumor. Unilateral right-sided varicocele are rare and result from compression or obstruction of the inferior vena cava by a tumor or thrombus. Color Doppler ultrasonography is used to confirm the diagnosis. So here you're taking a look at varicoceles. The cause of varicocele is incompetent or congenitally absent valves in the spermatic veins. The valves that normally prevent backflow are absent or do not close adequately, permitting blood to pool in the veins rather than flow into the venous system. A varicocele decreases blood flow through the testes, thus interferes with spermatogenesis and is a cause of infertility. If infertility is a problem, treatment consists of the ligation of the spermatic vein or the occlusion of the vein by percutaneous methods, such as a balloon, catheter, and sclerosing fluid. If varicocele is mild and fertility is not an issue, a scrotal support usually is sufficient to relieve symptoms of scrotal heaviness or dragging. A hydrocele is a collection of fluid within the tunica vaginalis. It is the most common cause of scrotal swelling. Hydroceles occur in 6% of male newborns and are congenital malformations that often resolve spontaneously in the first year of life. Surgical ligation is recommended if the hydrocele persists after 1 year of age. Hydroceles in adults may be caused by an imbalance between the secreting and absorptive capacities of scrotal tissues. Hydroceles ranging in size from slightly larger than the testes to the size of grapefruit or larger may be flaccid or tense. Compression of testicular blood flow may lead to atrophy. So here you're taking a look at the collection of fluid. So it's the true depiction of a hydrocele. The exact mechanism of idiopathic hydrocele development is unknown. A secondary hydrocele may result from trauma or infection of the testes or epididymis, or from a testicular tumor. Rapid accumulation of fluid occur after local injury, radiotherapy, or infection, or it may accompany testicular neoplasm. Chronic hydroceles are more common and occur in men older than 40 because of an imbalance between fluid secretion and reabsorption in the tunica vaginalis. A painless extratesticular mass that easily transilluminates is found on physical exam. Ultrasonography of a large hydrocele, which may conceal a testicular tumor, is recommended. Treatment is usually not required, unless a large, bulky hydrocele causes considerable physical discomfort or undesirable cosmetic appearance. Treatment for uncomplicated hydrocele is aspiration of fluid and injection of a sclerosing agent into the scrotal sac. The goal of treatment is to remove the hydrocele and prevent recurrence by sclerosing or excising the tunica vaginalis. Spermatoceles, or epididymal cysts, are benign cystic collections of fluid of the epididymis located between the head of the epididymis and the testes. Efferent ducts of the epididymis have potential for cystic dilation to form a spermatocele. Spermatoceles are filled with milky fluid that contains sperm. The spermatocele is differentiated from the hydrocele in that aspiration of the hydrocele recovers a clear, yellow fluid, and unlike a hydrocele, a spermatocele does not cover the entire anterior surface of the testes. So here you're taking a look at spermatocele. Spermatoceles manifest as discrete, firm, freely mobile masses distinct from the testes that may be transilluminated. Epididymal cysts do not require treatment. A spermatic cord tumor may feel like a tense spermatocele, but does not contain fluid and will not transilluminate. Spermatoceles that cause pain or discomfort are usually excised. Usually, however, spermatoceles are asymptomatic or produce mild discomfort that is relieved by scrotal support. Neither hydroceles nor spermatoceles are associated with infertility. That brings us to the cryptorchidism and an ectopy. Cryptochordism and ectopy. Cryptochordism is a condition of testicular maldescent, whereas ectopic testes has stayed from normal pathway of descent. The etiology of cryptochordism is considered to be multifactorial, and it occurs most often as an isolated disorder with no obvious cause. Ectopy may be caused by an abnormal connection at the distal end of the gubernaculum testis that leads the gonad to an abnormal position, usually at the superficial inguinal site. In cryptochordism, the descent of one or both testes is arrested, with unilateral arrest occurring more often than bilateral arrest. The testes may remain in the abdomen, or testicular descent may be arrested in the inguinal canal, or the penoscrotal junction. Cryptochordism is a common pathologic condition that occurs in 3% of full-term newborns and is decreased to 0.8% to 1.2% at 1 year of age. However, this rate increases significantly with low birth weight infants. For instance, the rate of cryptochordism at 3 months has been found to be 7.7% for infants with birth weights less than 2,000 grams. 2.5% of birth weights of 2,000 to 2,500 grams, and 1.4% for birth weight of 2,500 grams or more. The incidence of cryptorchidism in adults is 0.7 to 0.8%. Cryptorchidism is commonly associated with vassal or epididymal abnormalities. These congenital anomalies affect about 1/3 to 2/3 of newborns with cryptorchidism. Other structural anomalies include posterior urethral valves, upper tract abnormalities, and hypospadias. The presence of hypospadias as well as cryptorchidism raises the suspicion of mixed gonadal dysgenesis. It has been hypothesized that cryptorchidism may result from an absence or abnormality of gubernaculum, a cord-like structure that extends from the lower pole of the testes to the scrotum, a congenital gonadal or dysgenetic defect that makes the testes insensitive to gonadotropins, or a lack of maternal gonadotropins. Mechanical possibilities include a short spermatic cord, fibrous bands or adhesions in the normal path of the testes, or a narrowed inguinal canal. Chromosomal studies do not support a genetic component. Physiologic cryptorchidism, also called retractile or migratory testes, is an involuntary retraction of the testes out of the scrotum that occurs with excitement, physical activity, or exposure to cold, and is caused by the small mass of prepubertal testes and the strength of the cremaster muscle. This is a common phenomenon that is self-limiting. Physical examination discloses the absence of one or both testes in the scrotum and an atrophic scrotum on the affected side. If the undescended testes is in a vulnerable position, for example, over the pubic bone, an individual may complain of severe pain secondary to trauma. The adult male with bilateral cryptorchidism may be infertile. Ultrasonography, CAT scan, and MRI may be used to locate the intra-abdominal or non-palpable testes. Testicular cancer is also a well-established complication of cryptorchidism. In men with a history of unilateral cryptorchidism, neoplasms also develop more commonly in the contralateral testes. This finding suggests cryptorchidism affects the testes and is a process more significant than simple position of the testes in childhood. The risk of testicular cancer is 35 to 50 times greater for men with cryptorchidism or a history of cryptorchidism than for the general male population. Because definitive histologic change occurs in the cryptorchidal testes by 1 year of age, surgical correction is recommended earlier. Treatment often begins with administration of GnRH or human chorionic gonadotropin, HCG, hormones that may initiate descent, making surgery unnecessary. GnRH is given as a nasal spray in Europe and may enhance germ cell count even when the testes do not descend. If hormonal therapy is not successful, the testes is located and moved surgically in young children or removed. In adults and children older than 10 years, the testes that is properly placed in the scrotum provides adequate hormonal function and gives the scrotum a normal appearance. A successful operation does not ensure fertility if the testes is congenitally defective. Approximately 20% of males with unilateral undescended testes remain infertile, even though orchiopexy is performed by age 1. Most individuals with treated or untreated bilateral testicular maldescent have poor fertility. In addition, placement of the cryptorchid testes into the scrotal sac does not decrease the potential for malignancy. It does facilitate examination and tumor detection, however. So then we have torsion of the testes. Torsion of the testes is a rotation of the testes, which twists blood vessels in the spermatic cord. It causes an acute scrotum which is testicular pain and swelling. Differentiation between testicular torsion and two other common causes of acute scrotum is based on physical exam and history. This event is most common among neonates and pubertal adolescents, but it can occur in males at any age. Onset may be spontaneous or follows physical exertion or trauma. Torsion twists the arteries and veins in a spermatic cord, reducing or stopping circulation of the testes. Vascular engorgement and ischemia develop, causing scrotal swelling and pain. The manifestations are not relieved by scrotal elevation, rest, or scrotal support. On physical exam, men may have higher tender high-riding testes, a thickened spermatic cord, and an absent cremasteric reflex. Unlike epididymitis, the epididymis cannot be differentiated from the testes. Diagnostic testing includes urinalysis and color Doppler ultrasonography. Torsion of the testes is a surgical emergency. If the torsion cannot be reduced manually, surgery must be performed within 6 hours after the onset of symptoms to preserve normal testicular function. Surgery includes untwisting the spermatic cord and anchoring both testes in correct position within the scrotum and to prevent recurrences. With successful manual detorsion, surgical fixation should be done within a few days. So here you're taking a look at the torsion of the testes. And this following table is a good spot to hit pause, so you know how to do the diagnosis of selected conditions responsible for acute scrotum. Because there are different conditions, onset of symptoms, the age, tenderness, urinalysis, and cremasteric reflex. Orchitis. Orchitis is an acute infection of the testes and is uncommon except as a complication of systemic infection or as an extension of an associated epididymitis. Infectious microorganisms may reach the testes through the blood or the lymphatics, or most commonly by ascent through the urethra, vas deferens, and epididymis. Most cases of orchitis are actually cases of epididymorchitis. Occasionally, in middle-aged men, a nonspecific, apparently non-infectious inflammatory process occurs. It seems to be an autoimmune disease that triggers a granulomatous response to spermatozoa. So here you're taking a look at a picture of the orchitis, or the inflammation of the testes. Mumps is the most common infectious cause of orchitis and usually affects postpubertal males. The onset is sudden, occurring 3 to 4 days after the onset of parotitis. Signs and symptoms include high fever, reaching 40 degrees Celsius, marked prostration, bilateral or unilateral erythema, edema and tenderness of the scrotum, and leukocytosis. An acute hydrocele may develop. Urinary signs and symptoms which accompany epididymitis are absent. Atrophy with irreversible damage to spermatogenesis may result in 30% of affected testes. Bilateral orchitis does not affect androgenic function, but may cause permanent sterility. Treatment is supportive and includes bed rest, scrotal support, scrotal elevation, hot or cold compresses, and analgesic agents for relief of pain. If an acute hydrocele develops, it is aspirated. Testicular abscess usually requires orchiectomy or the removal of the testes. Appropriate antimicrobial drugs should be used for bacterial orchitis, and corticosteroids are indicated in proved cases of nonspecific granulomatous orchitis. That brings us to testicular cancer. Testicular cancer is a highly treatable, usually curable, cancer that most often develops in young and middle-aged men. For men with seminoma, the cure rate exceeds 90%. For those with low-stage seminoma or non-seminoma, the cure rate approaches almost 100%. Overall, testicular cancers are rare, yet they are the most common form of cancer in young men between age 15 to 35. The American Cancer Society estimates for testicular cancer in the US for 2017 suggests roughly 8,850 cases, and about 410 deaths will result from testicular cancer. In the US, the lifetime probability of developing testicular cancer is 0.2% for white men, an incidence that is 4 times higher than that for blacks. Testicular tumors are slightly more common on the right side than the left, a pattern that parallels the occurrence of cryptorchidism. About 1 to 2% of primary testicular cancers are bilateral, and 50% of these tumors arise from treated or untreated cryptorchid testes. So here you're taking a look at a testicular tumor. The pathophysiology. 90% of testicular cancers are germ cell tumors, arising from the male gametes. Germ cell tumors constitute 90% of testicular cancers and can be broadly classified into two types, the seminomas and the non-seminomas. Seminomas are the most common, are the least aggressive, and make up 30 to 35% of testicular cancer. Non-seminomas include embryonal carcinomas, teratomas, and choriocarcinomas, which are the most aggressive, but rare, form of testicular cancer. Testicular cancers can include a mix of types. In addition, testicular tumors can arise from specialized cells of the gonadal stroma. These tumors, which are named for their cellular origin, are Leydig cells, Sertoli cells, granulosa cells, and theca cell tumors and constitute less than 10% of all testicular cancers. The cause of testicular neoplasm is unknown. A genetic predisposition is suggested by the fact that the incidence is higher among brothers, identical twins, and other close male relatives. Genetic predisposition is supported further by statistics showing that the disease is relatively rare among Black Americans, Black Africans, Asians, and Native New Zealanders. Familial testicular germ cell tumors may be associated with transgenerational inheritance of epigenetic events. Risk factors include history of cryptorchidism, abnormal testicular development, HIV and AIDS, Klinefelter syndrome, and a history of testicular cancers. So clinical manifestations. Painless testicular enlargement is usually the first sign of testicular cancer. Enlargement is usually gradual and may be accompanied by a sensation of testicular heaviness or a dull ache in the lower abdomen. Occasionally, acute pain occurs because of the rapid growth, resulting in hemorrhage and necrosis. Roughly 10% of affected men have epididymitis, 10% have hydrocele, and 5% have gynecomastia, or hydrocele. The incidence of gynecomastia increases considerably to 30 to 45% in men who have Sertoli or Leydig tumors. Roughly 10% of individuals already have symptoms related to metastases at the time of initial diagnosis, which correlates with the typical delay of 3 to 6 months from the initial recognition to definitive treatment. Lumbar pain may be present and usually is caused by retroperitoneal node metastasis. Signs of metastasis to the lungs include a cough, dyspnea, and bloody sputum. Supraclavicular node involvement may cause difficulty swallowing and neck swelling. Alterations in visions or mental status. Papilledema in seizures may be experienced with metastasis to the CNS. Again, roughly 10% of affected individuals are asymptomatic. The tumor may be detected by the man's sexual partner or, incidentally, following trauma. So, what is the evaluation and our treatment plan? An incorrect diagnosis at the initial examination occurs in as many as 25% of men with testicular cancer. Epididymitis and epidydymyorchitis are the most common misdiagnoses. Others include hydrospeal, hydrocele, and spermatoceles. Evaluation begins with careful physical examination, including the palpation of the scrotal content, with the individual in the erect and supine position. The, the abdomen and lymph nodes are palpated to rule out metastasis. Signs of testicular cancer include abnormal consistency, induration, nodularity, or irregularity of the testes. A firm, non-tender testicular mass or diffuse enlargement is found in the majority of cases. Primary testicular cancer can be assessed rapidly and accurately by scrotal ultrasonography. Tumor markers are higher than normal in the presence of a tumor and may help detect a tumor that is too small to be palpated during physical exam or seen on imaging. Tumor type is identified after inguinal biopsy or orchiectomy. Scrotal incisions may cause dissemination of the tumor and increase the risk of local recurrence, and therefore are avoided. Chest X-ray, lymphangiogram, IV pyelograms, abdominal ultrasounds, and CAT scans are used in clinical staging of the disease. Treatment is based on type of tumor, stage of disease, general health, and age. Besides surgery, treatment involves radiation and chemotherapy singly or in combination. A number of factors that influence the prognosis. They include histology of the tumor, the stage of the disease, and the selection of appropriate treatment. Serum markers such as alpha fetoprotein, beta HCG, and lactate dehydrogenase are useful for detecting metastasis and assessing response to therapy. With appropriate treatment, survival rates from testicular cancers are excellent, although some affected men have persistent paresthesias, Raynaud phenomenon, or infertility. According to the National Cancer Institute, over 5-year survival rates from testicular cancer was 95% between 2006 and 2012. If the cancer was confirmed to the testes, at the time of diagnosis, the survival rate was 99.3% and dropped only slightly to 96.1% with regional extension. For those with distant metastasis, the survival rate was 73.9%. Orchiectomy does not affect sexual function, but infertility can result from chemotherapy or surgical removal of affected abdominal lymph nodes if the nerves necessary for ejaculation are severed. After orchiectomy, testicular silicone implants may be used to restore normal scrotal appearance. So, this following table here shows testicular tumors of germ cell origin. So you have the different cell types, the occurrence, and the metastatic pattern. And then your prognosis and remission. I'm going to see if I can get most of it all into one spot so that we can hit pause at appropriate locations. So that brings us to epididymitis. Epididymitis, or the inflammation of the epididymis, generally occur in sexually active young males, so younger than 35 years of age, and is rare before puberty. In young men, the usual cause is a sexually transmitted microorganism, so your gonorrhea and your trichomatis. Men who practice unprotected anal intercourse may acquire sexually transmitted epididymitis because of E. coli. Haemophilus influenza, tuberculosis, Cryptococcus, and brucella. In men older than 35 years of age, Enterobacteriaceae and Pseudomonas aeruginosa, associated with UTI infections and prostatitis, also may cause epididymitis. Besides an infectious etiology, epididymitis may result from a chemical inflammation caused by the reflux of sterile urine into the ejaculatory ducts. It is associated with urethral stricture, congenital posterior valves, and excessive physical straining, in which increased abdominal pressure is transmitted to the bladder. Chemical epididymitis is usually self-limiting and does not require evaluation or intervention unless it persists. So here you're taking a look of epididymitis due to gonorrhea. So the pathophysiology. The pathogenic microorganism usually reaches the epididymis by ascending the vasa deferentia from an already infected urethra or bladder. The presence of bacteria initiates the inflammatory response, causing symptoms of bacterial epididymitis. Epididymitis caused by heavy lifting or straining results from reflux of urine from the bladder into the vas deferens and the epididymis. Urine is extremely irritating to the epididymis and initiates the inflammatory response, called chemical epididymis. Clinical manifestations. The most common one is going to be pain. Pain is the main symptom of epididymitis. Scrotal or inguinal pain is caused by inflammation of the epididymis and its surrounding tissues. The pain is usually acute and severe. Flank pain may occur if, as the urethra passes over the spermatic cord, edematous swelling of the cord obstructs the urethra. The individual may have pyuria and bacteriuria and a history of urinary symptoms, including urethral discharge. The scrotum on the involved side is red and edematous as a result of inflammatory changes. The tail of the epididymis, near the lower pole of the testes, usually swells first. Then swelling ascends to the head of the epididymis. The spermatic cord also may be swollen and tender. Complications of the epididymitis include an abscess formation, infarction of the testes, recurrent infection, and infertility. Infarction probably is caused by thrombosis of the prostatic vessel, secondary to severe inflammation. Recurrent epididymitis may result from inadequate initial treatment or failure to identify or treat predisposing factors. Chronic epididymitis can cause scarring of the epididymal endothelium. Once scarring has occurred, treatment with antibiotics is ineffective because adequate antibiotic levels cannot be achieved within the epididymis. So our evaluation and treatment, therefore, a history of recent urinary tract infection or urethral discharge suggests the diagnosis of epididymitis. The relief of pain when the inflamed testes and the epididymis are elevated, the Prain sign, is also diagnostic. Definitive diagnosis is based on culture or gram stain of the urethral swab. Epididymal aspiration may be necessary to obtain a specimen, especially if the individual has been taking antibiotics and has sterile urine. Treatment includes antibiotic therapy for the infection itself. Analgesics, ice, and scrotal elevation can provide symptomatic relief. If the individual does not steadily improve, he should be reevaluated for possible complications, such as abscess formation, sepsis, or continued infection. Bed rest and scrotal elevation are recommended until the scrotum is no longer tender. Scrotal elevation facilitates maximal lymphatic and venous drainage. Abscess formation is rare with antibiotic therapy. However, if an abscess occurs and persists, it is drained surgically, and an orchiectomy may be indicated. Complete resolution of swelling and pain may take several weeks to months. The individual sexual partner should be treated with antibiotics if the causative microorganism is an STD. So, disorders of the prostate gland. The most common that everybody knows about is, of course, the benign prostatic hyperplasia, or BPH, also known as benign prostatic hypertrophy, which is the enlargement of the prostate gland. Because the major prostatic changes are caused by hyperplasia, not hypertrophy, benign prostatic hyperplasia is the preferred term. This condition becomes problematic as prostatic tissue compresses the urethra, where it passes through the prostate, resulting in frequency of lower urinary tract symptoms. The prevalence among U.S. men 60 years and older is 50%, and among men 70 years and older is almost 90%. BPH is common and involves a complex pathophysiology with several endocrine and local factors and a remodeled microenvironment. Its relationship to aging is well documented. At birth, the prostate is pea-sized, and growth of the gland is gradual until puberty. A period of rapid development continues until the third decade of life, when the prostate reaches its adult size. Around 40 to 45 years of age, benign hyperplasia begins and continues slowly until death. Although dihydrotestosterone is necessary for normal prostatic development, its role in BPH remains unclear. Among all androgen metabolizing enzymes within the human prostate, the 5-alpha reductase is the most powerful. The level of this reductase positively corresponds to the age-dependent DHT level. Therefore, although 5-alpha reductase and DHT levels decrease with age in the epithelium, they remain relatively constant in the stroma of the prostate gland. So here you see different zones of the prostate. So it's a good spot to hit pause, so you can hit review. It's pathophysiology. Current causative theories of BPH focus on the levels and the ratios of the endocrine factors, such as the androgens, estrogens, gonadotropins, and prolactin, and changes in the balance between the autocrine, paracrine, growth stimulatory, and growth inhibitory factors. These factors include insulin-like growth factors, epidermal growth factor, nerve growth factor, fibroblast factors, IGF binding proteins, and transforming growth factor beta. Aging and circulating androgens are associated with BPH and enlargement. These factors are predisposed as disrupting the balance of growth factor signaling pathways and the stromal and epithelial interactions, creating a growth promoting and tissue remodeling microenvironment. However, BPH is a multifactorial disease, and not all men respond well to available treatments, suggesting factors other than androgens are involved. Testosterone, the primary circulating androgen in men, also can be metabolized through a CYP19 aromatase into the potent estrogen, estradiol 17 beta. The prostate is an estrogen target tissue, and estrogens directly and indirectly affect growth and differentiation of the prostate. The precise role of endogenous and exogenous estrogens in directly affecting prostate growth and differentiation in the context of BPH is an understudied area. Estrogens and selective estrogen receptor modulators have been shown to promote or inhibit prostate proliferation, illustrating their potential roles in the development of BPH as therapy. Taken together, these interactions lead to an increase in prostate volume. The remodeled stroma promotes local inflammation with altered cytokine, reactive oxygen nitrogen species, and chemoattractants. The resultant increased oxygen demands of proliferating cells causes a local hypoxia that induces angiogenesis and changes to fibroblasts. Functional and phenotypic changes of fibroblasts to the myofibroblasts is a hallmark of the remodeled microenvironment. BPH begins in the periurethral glands, which are the inner glands or layers of the prostate. The prostate enlarges as nodules form and grow, and glandular cells enlarge. The development of BPH occurs over a prolonged period, and changes within the urinary tract are slow and insidious. So, clinical manifestations. Preclinical studies demonstrate that the activation of a chronic inflammatory prostatic response plays an important role in the pathogenesis and progression of BPH and prostate cancer. Again, roughly 40 to 70% of men with BPH-related lower urinary tract symptoms harbor chronic inflammation at the time of pathologic evaluation. As nodular hyperplasia and cellular hypertrophy progress, tissues that surround the prostatic urethra usually compress, but do not always cause bladder outflow obstruction. These symptoms are sometimes called the spectrum of lower urinary tract symptoms. Symptoms include the urge to urinate often, a delay in starting urination, and decreased force of the urinary stream. As the obstruction progresses, often over several years, the bladder cannot empty all the urine, and the increasing volume leads to long-term urine retention. The volume of urine retained may be great enough to produce uncontrolled overflow incontinence, with any increase in intra-abdominal pressure. At this stage, the force of the urinary stream is significantly reduced, and much more time is required to initiate and complete voiding. Hematuria, bladder or kidney infection, bladder calculi, acute urinary retention, hydronephrosis, and renal insufficiency are common complications. Some men initially have signs of uremia and renal failure. On digital rectal examination, the hyperplastic prostate is a soft or firm enlargement with a smooth mucosal surface and no discernible distinction between lobes. Asymmetry is common. The palpated prostate does not always reflect the degree of BPH because a substantial portion of the enlargement is intravesicular. 30% of men with mild to moderate symptoms improve with watchful waiting. So, our evaluation and treatment then. For those in the clinical setting, we always give medication. The number one we go for is Flomax. So, our evaluation and treatment, therefore, diagnosis is made from a medical history, physical exam, and lab tests, including urinalysis. Careful review of symptoms is necessary. A digital rectal exam and PSA are conducted to determine hyperplasia. Measurement of PSA level alone, however, cannot determine whether symptoms are caused by BPH because the level of PSA is elevated in both BPH and prostate cancer. So don't just go by the PSA. I'm saying this for a reason. Annual DREs are used to screen men older than 40 years of age for BPH, sooner in high-risk men. If there is marked enlargement of the prostate, or if moderate to severe symptoms or complications are present, transrectal ultrasounds is used to determine bladder and prostate volume and the presence of residual urine. Urinalysis measurements of serum creatinine and blood urea nitrogen levels, uroflowmetry, determination of post-void residual, urine pressure flow study, cystometry, cystourothroscopy are used to determine kidney and bladder function. BPH has been treated successfully with drugs. Alpha adrenergic blockers, prazosin and tamsulosin, are used to relax the smooth muscle of the bladder and the prostate. Anti-androgen agents such as finasteride selectively block androgens at the prostate cellular level and cause the prostate gland to shrink. By shrinking the prostate, these drugs have been shown to improve BPH-related symptoms and reduce the risk of future urinary retention and BPH-related surgery. Your alpha-adrenergic blockers do not affect PSA level and have no effect on prostate cancer risk. Newer, minimally invasive procedures include interstitial laser therapy, transurethral radiofrequency procedures, cooled thermotherapy, and prostate artery embolization. When necessary, the hyperplastic tissue may be removed surgically to prevent the serious consequences of urethral obstruction. A permanent indwelling catheter is inserted if the individual cannot tolerate surgery. It also should be noted that new techniques in genomics, proteomics, and epigenetics have led to the discovery of aberrant signaling pathways, novel biomarkers, DNA methylation signatures, and potential genetic specific targets. As such, the ability to risk stratify men with symptomatic benign prostate hyperplasia, identify those at higher risk for progression, and seek alternative therapies for those in whom conventional options are likely to fail, will become the standard of target therapy in the future. Prostatitis. Prostatitis is an inflammation of the prostate. Some degree of prostatic inflammation is present to 4 to 36% of male population, increasing to 50% in older men. Inflammation is usually limited to a few of the gland excretory ducts. Prostatitis syndromes have been classified by the National Institute of Health as 1. Acute bacterial prostatitis, 2. Chronic bilateral prostatitis, 3. Chronic pelvic pain syndrome, and 4. Asymptomatic inflammatory prostatitis. So if you look at the following box, you'll see more information on all 4 of them. Your acute bacterial prostatitis and your chronic bilateral prostatitis are caused mostly by a gram-negative Enterobacteriaceae and Enterococci species, which originate in the gastrointestinal flora. The most common microorganism is E. coli, which is identified in the majority of infections. Klebsiella, P. aeruginosa, and Serratia species are common gram-negative cultured microorganisms. Non-bacterial prostatitis syndromes are caused by a cascade of inflammatory, immunologic, neuroendocrine, and neuropathic mechanisms in which the initiating cause is unknown. So here is a good spot to hit pause so you can review all the differences in the 4 different categories. Bacterial prostatitis, or category 1, is an ascending infection of the urinary tract that tends to occur in men between the ages of 30 and 50, but also is associated with BPH in older men. Infection stimulates an inflammatory response in which the prostate becomes enlarged, tender, firm, or boggy. The onset of prostatitis may be acute and unrelated to previous illness, or it may follow catheterization or cystoscopy. The clinical manifestation of acute bacterial prostatitis are those of urinary tract infection or pyelonephritis. Sudden onset of malaise, low back and perineal pain, high fever, and chills is common, as are dysuria, inability to empty the bladder, nocturia, and urinary retention. The individual may have symptoms of lower urinary tract obstruction, such as a slow, small, narrowed urinary stream, which may be a medical emergency. Acute inflammatory prostatic edema can compress the urethra, causing urinary obstruction, Systemic signs of infection include sudden onset of a high fever, fatigue, arthralgia, and myalgia. Prostatic pain may occur especially when the individual is in an upright position because the pelvic floor muscles tighten with standing and the prostate gland is compressed. Some individuals experience low back pain, painful ejaculation, and rectal or perineal pain. Palpation discloses an enlarged, extremely tender and swollen prostate that is firm, indurated, and warm to the touch. Because the ABP is usually associated with a bladder infection caused by the same microorganism, urine cultures disclose its identity. Prostatic massage may express enough secretion from the urethra for direct bacterial examination, but massage may be painful and increases the risk that the infection will ascend to adjacent structures or enter the bloodstream and cause septicemia. To resolve the infection and control of its spread, individuals may require antibiotics. In severe cases, the individual is hospitalized and treated with IV antibiotics, followed by oral antibiotics. Analgesics, antipyretics, bed rest, and adequate hydration also are therapeutic. Complications include urinary retention that resolves with antibiotic therapy, prostatic abscess that may rupture into the urethra, rectum, or perineum, epididymitis, bacteremia, and septic shock. Urinary retention requiring drainage is best managed with a suprapubic catheter. Fully catheterization is contraindicated during an acute infection. Your chronic bacterial prostatitis, or category 2, is characterized by recurrent urinary tract symptoms and persistence of pathogenic bacteria in urine or prostatic fluid. The form of prostatitis is the most common recurrent UTI in men. Symptoms may be similar to those of an acute bladder infection, such as frequency, urgency, dysuria, perineal discomfort, low back pain, myalgia, arthralgia, and sexual dysfunction. The prostate may only be slightly enlarged or boggy, but it may be fibrotic because of repeated infections that can cause it to be firm and give it an irregular shape. When the initial urine sample is bacteria-free, prostatic massage is used to express secretion. Subsequently, the first 10 ml of voided urine is collected and examined microscopically. Prostatic secretions showing more than 10 white blood cells per high power field and macrophages containing fat are indicative of bacterial infection. Diagnosis is confirmed via culture. A pelvic X-ray or TRUS may show prostatic calculi. Treatment of chronic bacterial prostatitis is difficult because it is often caused by prostatic calculi. Calculi are silent and are found in up to 50% of men with prostatitis. And infected calculi can serve as a source of bacterial persistence and relapsing UTI infections. Calculi harbor pathogens within the stone, and consequentially, pathogens cannot be eradicated from the urinary tract. Permanent cure is achieved via surgical intervention. Bringing us to chronic prostatitis, the chronic pelvic pain syndrome, or stage or category 3 rather. It is diagnosed when no pathogenic bacteria can be localized to the prostate and is further divided into subcategories A and B. Category 3A refers to inflammatory chronic pelvic pain syndrome, where the white blood cell count is elevated and localized to the prostate. Symptoms tend to be milder, but are persistent and annoying. Presumably, non-infectious prostatitis or pain is caused by reflux of sterile urine into the ejaculatory ducts because of high-pressure voiding. Reflux may be triggered by spasms of the external or internal sphincter, Category 3B is non-inflammatory. In Category 4, individuals are asymptomatic but have an increase in the number of bacteria and white blood cells localized to the prostate. Microorganisms suspected of causing CPPS include E. coli, Enterobacter P. aeruginosa, and Helicobacter pylori, a new suspect. Men with non-bacterial prostatitis may complain of pain or a dull ache that is continuous or spasmodic in the suprapubic, infrapubic, scrotal, penile, or inguinal area. Other symptoms are pain on ejaculation and urinary symptoms, such as frequency of urination. The prostate gland generally feels normal on palpation. Non-bacterial prostatitis is a diagnosis of exclusion. Digital examination of the prostate, bacterial cultures of the urogenital tract, microscopic examination of expressed prostatic fluid, urethroscopy, and urodynamic studies are used to verify the diagnosis of non-bacterial prostatitis. There is no generally accepted treatment for non-bacterial prostatitis. Hot sitz baths, bed rest, alpha blockers, anticholinergics, and anti-inflammatory drugs can relieve symptoms. So that brings us to cancer of the prostate. Prostate cancer is the most common diagnosed non-skin cancer in men in the US, with a lifetime risk for diagnosis currently estimated at 15.9%, according to the 2012 U.S. Preventative Service Task Force Screening Recommendation Document. The incidence varies greatly worldwide, but it is still considered to be the second most frequently diagnosed cancer and the sixth leading cause of death worldwide. Importantly, incidence rates vary by more than 25-fold worldwide, and the highest rates recorded mostly in developed countries, including Oceania, Europe, and North America, largely because of the wide overuse of PSA testing. Screening with PSA can amplify the incidence of prostate cancer by allowing detection of prostate lesions that, although meeting the pathologic criteria for malignancy, may have low potential for growth and metastasis. In countries with higher use of PSA testing, such as the US, Canada, Australia, and Nordic countries, trends in incidence rates follow similar patterns. So here you see a graph of the selected world population. Different from Western countries, incidence and mortality rates are rising in several Asian, including Japan, and Central and Eastern European countries. Death rates have been decreasing in several countries, including Australia, Canada, and the UK, the United States, Italy, and Norway, in part from improved treatment. Males of African descent in the Caribbean have the highest mortality rates from prostate cancer in the world. Most cases of prostate cancer have a good prognosis, even without treatment, but some cases are aggressive. The lifetime risk for dying of prostate cancer is 2.8%. Prostate cancer is rare before the age of 50, and very few men die from it before the age of 60. Indeed, more than 75% of all prostate cancers is diagnosed in men older than 65. With aging, most of the androgen metabolizing enzymes undergo significant alteration, and older age, race, and family history remain the well-established risk factors. There are, however, dietary factors. Although evidence exists for a dietary role in prostate cancer, the epidemiologic evidence is inconsistent. The problem has been confounded by a lack of biomarkers for certain nutrients, difficulties in measuring and quantifying diet, and a limitation of clinical trials to study diet over time. Important are the effects of diet on signaling pathways. hormones, oxidative stress, and reactive oxygen species. The nutrients and epidemiology of prostate cancer that have received the most attention include carotenoids, fat, vitamin E, vitamin D, calcium, and selenium. Less studied are isoflavones, curcumin, lycopene, zinc, green tea, and omega-3 polyunsaturated fats and sulforaphane. Associ- Associations between obesity and prostate cancer are not clear, with some research inconsistencies, but obesity seems to be negatively associated with more indolent prostate cancers and positively associated with more aggressive disease and a worse outcome. In, pro- in process is a randomized clinical trial of diet and early stage prostate cancer. Men's eating and living study. The hypothesis for meal is that a change in diet from a high intake of animal products to the consumption of more fruits and vegetables will slow progression of the indolent form of the aggressive form of prostate cancer. Likewise, a recent systemic review found that physical activity does not significantly reduce the risk of prostate cancer. However, the authors noted that vigorous exercise may reduce the risk of an aggressive tumor. Because adipose tissue is increasingly being regarded as hormonally active tissue, high body fat and obesity need in-depth exploration to understand the associated risk of prostate problems. Adipose tissue is now known to affect circulating levels of several bioactive messengers, and therefore could affect the risk of developing prostate problems in addition to several other well-recognized health problems. High energy intake indicates that this may indeed increase insulin levels and insulin-like growth factor, a powerful carcinogen agent. A meta-analysis found IGF-1 as a potential mechanism for the associations between milk intake and prostate cancer risk. Investigators suggest a positive association between a high-fat milk intake and prostate cancer progression among individuals diagnosed with localized prostate cancer. Although epidemiologic studies have revealed some dietary factors modulating the risk of advanced prostate cancer, there is a lack of definitive evidence supporting the preventive role of diet against prostate cancer. More robust, high-quality research trials are needed to guide understanding of the complex relationship between diet and prostate cancer. So here is some nutrition and disease information and the diet for prostate cancer. A good spot to hit pause if you want to make yourself more familiar. I'll see if I can slow down for you so that it's all in relatively small sections. Again, if I'm ever going too quickly, always make sure you hit pause. And just because I am not reading all of these to you does not mean it is not important. But that's why I always give you the option to pause. That brings us to hormones. I know that anyone who is going through the Walden program wants you to stop reading here. However, no. I think hormones are still important to know in terms of the male reproductive system. So let's keep on keeping on, and we'll keep on going. Hormones. The prostate cancer develops in an androgen-dependent epithelium and is usually androgen sensitive. Androgens are synthesized not only in the testes, accounting for 50 to 60% of the total testosterone in the prostate, but also in the prostate gland itself. In a process called intraprostatic conversion, the hormone dihydroepiandrosterone, or DHEA, produced by the adrenal glands, is converted to the testosterone and then into DHT in the prostate. Additionally, prostate cancer cells have been reported to make androgens from cholesterol. However, these overall relative contributions from the intratumoral sources remain to be determined. Population studies have not, however, provided clear and convincing patterns involving associations between circulating hormone concentrations and prostate cancer risk. A recent case control study found the risk of aggressive prostate cancer was strongly inversely associated with estradiol testosterone ratios and positively associated with 2-hydroxyestrone 16-alpha hydroxyestrone ratios. These findings suggest that sex steroid hormones, specifically the estrogen-androgen balance, may be important in the development of aggressive prostate cancer. Thus, there is universal agreement that androgens are important for prostatic growth, development, and maintenance of tissue balance, but their role in cancer is still controversial. As such, it also has been hypothesized that reducing the concentration of active hormones in the systemic circulation may be insufficient to block cancer progression, because this action selects the tumor cells that can generate active steroids for circulating precursors. Evidence for involvement of the 5-alpha reductase activity, which is critical in androgen activity in the prostate, is contradictory and inconsistent. A prevention study has provided some of the strongest hormonal data with the drug finasteride, which inhibits the 5-alpha reductase. The 7-year intervention study reduced prostate cancer risk in healthy men by about 25%. Important, however, was the more high-grade tumor were found in those men who developed prostate cancer while taking the drug. In men younger than 50 years, circulating levels of androgens and estrogens appear to be higher in men of African descent than in European American men. So here we're taking a look at the sources of the androgens and aromatase and estrogen signaling in the prostate. So here's a good spot to hit pause if you're unfamiliar with how that works. Despite the well-documented importance of androgens, their pathophysiologic process in prostate disease is incomplete. Identifying cellular signaling pathways that become corrupted and facilitate metastasis in the presence of androgens is the focus of recent work. Investigators suggest that inhibition of the CXCR7, the chemokine receptor 7, function might decrease metastatic potential by altering cell motility. Androgens are also metabolized to estrogens through the action of enzyme aromatase, and a growing body of evidence implicates estrogen in the etiology of prostate disease. Importantly, the aberrant expression of aromatases has been implicated in other tissue, such as the breast and endometrium. Only a few associations with prostate cancer study risk have been observed consistently, and their associations are weak. 1. Slightly higher circulating testosterone and estrogen levels and lower DHEA levels in high-risk black men as compared with lower-risk European American men. And 2. A cytosine adenine guanine repeat length polymorphism in the androgen receptor gene associated with increased risk and increased receptor activity. Moreover, in a more recent collaborative analysis of existing worldwide epidemiologic data, the endogenous hormones and prostate cancer collaborative group found no associations between the risk of prostate cancer and serum concentrations of testosterone. calculated free testosterone, dihydrotestosterone, and dehydroepiandrosterone sulfate, androstenedione, and androstenediol, glucuronide, estradiol, or calculated free estradiol. As the result of the above-mentioned endogenous hormones and prostate cancer collaborative groups suggest, investigations directed at understanding the hormonal basis of prostate carcinogenesis have numerous problems. Understanding the complexities of interacting hormones and differentiating the effects of a single hormone are profound. In addition, only single blood samples are generally available. Tissue hormone samples important for paracrine signaling are not consistently measured, and within subject variations over time and differences in circadian rhythms cannot be adequately measured. The results of several animal studies do support elevation of levels of bioavailable and bioactive androgens in the circulation and in the target tissue as an important risk factor. Animal studies also indicate that increased biologic activity of the androgen receptors may be associated with prostate cancer. See the Pathophysiology section for the prostate cancer for more thorough discussion of the role of hormones in the pathogenesis of prostate cancer. A vasectomy. Vasectomy has been identified as a possible risk factor for prostate cancer in case-controlled and cohort studies. Three mechanisms by which a vasectomy could increase risk are elevation of levels of circulating androgens, immunologic mechanisms involving antigen sperm antibodies, and reduction of seminal fluid levels of 5-alpha dihydrotestosterone, the active metabolite of testosterone in the prostate, in vasectomized men. These results suggest an elevation of circulating free testosterone level following a vasectomy. However, with these combined mechanisms, it is unlikely that vasectomy plays a causal role. In fact, a recent systematic review and meta-analysis of cohort studies indicated that a vasectomy may not contribute to the risk of prostate cancer. Chronic inflammation. Data from the medical therapy of prostatic symptoms study suggests that the risk of BPH progression and acute urinary retention is greater in men with prostatic inflammation. Preclinical studies have claimed that inflammatory mediators are involved in prostate cancer development, and therefore suggested these as attractive targets for intervention. However, among the many pro-inflammatory mediators, there is no consensus regarding the identity of the primary ones. In a 5-year longitudinal study of the influence of chronic inflammation on prostate cancer, 33 of 144 men presented with chronic inflammation in their initial biopsy. The investigators also found prostatic hyperplasia and proliferative inflammatory atrophy in those with chronic inflammation. Upon repeat biopsy, 29 new cancers were diagnosed, representing a new cancer incidence of 20%. In contrast, of the 33 initially showing no inflammation, 2 were found to have adenocarcinoma. Certain metabolic comorbidities, including obesity, diabetes, sleep apnea, and erectile dysfunction, may be linked to both BPH and inflammation. The causes of chronic inflammation are unknown. Thus, chronic inflammation may be an important risk factor for prostatic adenocarcinoma. Here, we're going to take a look at the possible causes of prostate inflammation. Genetic and epigenetic factors. Other possible causes are genetic predisposition. Genetic studies suggest that strong familial predisposition may be responsible for 5 to 10% of prostate cancers. Compared with men with no family history, those with one first-degree relative with prostate cancer have twice the risk of those with 2 first-degree relatives have 5 times the risk. A germline mutation in the breast cancer predisposition gene 2 are the genetic events known to date that confer the highest risk of prostate cancer. Although the role of the BRCA2 and BRCA1 in prostate tumorigenesis remains unrevealed, deleterious mutations in both genes have been associated with more aggressive disease and poor clinical outcomes. The strongest predictors are the BRCA2 mutations and the highly penetrant G84E mutation and HOXB13. Men with BRCA2 germline mutations have a 20-fold increase in risk for prostate cancer. Using previously estimated population carrier frequencies, investigators have found recently that deleterious BRCA1 mutations confer a relative risk of prostate cancer of approximately a 3.75-fold, translating to a 8.6 cumulative risk for by the age of 65. A common type of somatic mutation that gives rise to the chromosomal rearrangement is the ETS gene. The most common epigenetic alteration in prostate cancer is hypermethylation of the glutathione S transferase gene. This gene is located on chromosome 11 and is part of the pathway that helps protect against carcinogen damage. More than 30 independent peer-reviewed studies have reported a consistent high sensitivity and specificity of GSTP1 hypermethylation in prostatectomy or biopsy tissue. A number of other epigenetic modifications found on tumor suppressor genes include BTEN, RB, the P16INK4A or alpha, MLH1, MSH21, and APC. There is no clear evidence of a causal link between BPH and prostate cancer, even though they may often occur together. Variations in several other genes related to inflammatory pathways might affect the probability of developing prostate cancer. The presence of multiple risk alleles is more highly predictive than a single allele. So it's pathophysiology. More than 95% of prostatic neoplasms are histologically similar to adenocarcinomas and rely on androgen-dependent signaling for their development and progression. Most of these neoplasms occur in the periphery of the prostate. Prostatic adenocarcinoma is a heterogeneous group of tumors with a diverse spectrum of molecular and pathologic characteristics, and therefore clinical behaviors and challenges. The biologic aggressiveness of the neoplasm appears to be related to the degree of differentiation rather than the size of the tumor. So here's a good spot to hit pause if you need help determining the grade of prostate cancer with the Gleason score, especially if you're unfamiliar with the Gleason score. Hormonal levels. Just as the testicles are the male equivalent of the female ovaries, the prostate is the male equivalent of the female uterus. In both situations, they originate from the same embryonic cells. This may be important in understanding the role of the associated hormone testosterone, DHT, and estrogen in prostate carcinogenesis. Testicular testosterone synthesis and serum testosterone levels usually fall as men age. However, the levels of estradiol do not decline. The relationship between hormones and the pathophysiology of prostate carcinogenesis is incomplete and controversial. The main issue and controversies include the source of androgen production outside of the testes, or extratesticular sources. And 2, the role of prostatic androgen receptors. 3, the role of estrogen, aromatase enzyme, and estrogen receptors, the ER alpha and ER beta, and 4, the role of the surrounding microenvironment or stroma. The hormone concentrations in prostate tissue are important, and there's little evidence that circulating hormone levels are associated with future risk of prostate cancer. Testicular testosterone provides the main source of androgens in the prostate and is the major circulating androgen, whereas DHT predominates in the prostate tissue and binds to the AR with greater affinity than does T. The adrenal cortex contributes the far less potent DHEA that promotes synthesis of androgens in the prostate, in the target tissue, and to the lesser extent in the testes themselves. Testosterone is converted to a DHT by the enzyme 5-alpha reductase. Thus, DHT is the most potent intraprostatic androgen. About half of circulating testosterone is bound to sex hormones, binding globulin. About half binds to albumin, and about 1 to 2% exists in its free state. Free testosterone, including testosterone dissociated from albumin and possible SHBG, enters the prostate cell where it is converted to DHT. DHT is a paracrine hormone because it affects the local environment or stroma. Several intraprostatic enzymes encoded by genes HSD3A and HDS3B are activated by DHT and are important components of intraprostatic androgen regulation. Here we're going to take a look at the testosterone and conversion of dihydrotestosterone. One mechanistic effect of estrogen is determined by the two receptors, your ER alpha and beta. ER alpha leads to abnormal proliferation, inflammation, and the development of pre-malignant lesions. Increased expression of ER alpha has been found to be associated with prostate cancer progression, metastasis, and the so-called castration-resistant phenotype. A specific oncogene is regulated by ERs and those hormones that stimulate ER alpha receptor-like endogenous estrogens can stimulate oncogene expression. In contrast, the ER betas leads to anti-proliferative and anti-inflammatory effects, differentiation and maturation of prostatic epithelial cells, and potentially anti-carcinogenic effects that act in concert or balance the actions of ER alpha and androgens. Normally, a small amount of estrogen is produced per day. Estrone and estradiol by aromatization and androstenedione and testosterone respectively. This reaction is catalyzed by the aromatase enzyme system. A small quantity of estradiol is released by the testes. The remainder of the estrogen in males is produced by adipose tissue, liver, skin, brain, and other non-endocrine tissue. Thus, testosterone is a precursor of the two hormones, DHT and estradiol. Studies show aromatase is expressed in stromal tissue in the benign human prostate gland. Thus, it appears that both normal prostate and benign prostate have the capacity to locally metabolize androgens to estrogens through aromatase. Investigators have demonstrated altered aromatase expression in prostate cancers. Data mostly from animal studies suggest that for androgens to cause prostate cancer, they must be aromatized to estrogen and act in concert with the estrogen metabolites. The androgen receptor-mediated activity of androgens and the estrogen receptor-mediated effects of estrogen metabolites are likely to be necessary, but estrogen genotoxicity appears to be a probable critical factor as well. Prostate carcinogenesis can occur only when all these mechanisms are active. The effects of progesterone are under-investigated. Stromal progesterone, PR, signaling may play a role in the prostate cancer development and progression. Chronic exposure to arsenic as well as estrogen is a known risk factor for prostate cancer. Though the evidence suggests that exposure to arsenic or estrogens can disrupt normal DNA methylation patterns and histone modifications, the mechanism by which these chemicals induce epigenetic changes are not fully understood. Moreover, The epigenetic effects of co-exposure to these two chemicals are not well known. Investigators have revealed that exposure to arsenic, estrogen, and the combination alters the expression of epigenetic regulatory genes and changes global DNA methylation and histone modification patterns. Most of the androgen metabolizing enzymes undergo a significant age-dependent alteration. In epithelium, both the 5-alpha reductase activity and the DHT level decrease with age, whereas in stroma, not only the 5-alpha reductase activity, but also the stromal DHT level is rather constant over the lifetime. In contrast to the relatively unaltered DHT level, over time, the estrogen concentration follows an age-dependent increase. Thus, the age-dependent decrease of the DHT accumulation in the epithelium and the concomitant increase of the estrogen accumulation in stroma lead to a tremendous increase with age of the estrogen-androgen ratio in the human prostate. In animal studies, chronic exposure to testosterone plus estradiol is strongly carcinogenic, whereas testosterone alone is weakly carcinogenic. In mice studies, elevated testosterone level in the absence of estrogen leads to the development of hypertrophy and hyperplasia, but not malignancy. High estrogen and low testosterone levels have been shown to lead to inflammation with aging and the emergence of the precancerous lesions. The mechanism is not clearly understood and may involve estrogen-generated oxidative stress and DNA toxicity, and it requires androgen-mediated and estrogen receptor-mediated processes, such as changes in sex steroid metabolism and receptor status. In addition, there are changes in the balance between the autocrine, paracrine, growth stimulatory, and growth inhibitory factors, such as the insulin-like growth factors. When exogenous estradiol is added to testosterone treatments of rats, prostate cancer incidence is markedly increased, and even a short course of estrogen treatments results in a high incidence of prostate cancer. Androgen receptor signaling. The androgenic hormone response in the normal prostate and in prostate cancer are mediated by AR signaling. Exactly how AR drives the growth of prostate cancer's cells is not fully known. Several mechanisms have been suggested, however, and specific pathways of signaling are important because they can provide novel therapeutic targets. A study using minimal animal models found that loss of androgen receptors function prevented prostatic carcinogenesis, malignant transformation, and metastasis. Tissue-specific evaluation of androgen hormone action demonstrated that epithelial androgen receptor was not necessary for prostate cancer progression, whereas stromal androgen receptors was essential for prostate cancer progression, malignant transformation, and metastasis. Changes in AR signaling in the surrounding stroma can significantly affect tumor cell behavior, emerging in the mechanism of AR function in prostate stroma. In the benign prostate, the chief stromal cells are smooth muscle cells, and a majority express AR. In tumor stroma, the chief stromal cells are myofibroblasts. Recent work involves the identification of AR signaling in fibroblast, myofibroblasts, and prostate stroma. Key is the role of mesenchymal hormone signaling in the development of both male and female reproductive organs, with expression of the appropriate hormone receptors and adjacent stromal necessary for organ-specific response to estrogen, progesterone, and testosterone. Stromal AR activity has been investigated in animal models in early-stage cancer and AR signaling and tumor formation. Evidence supports stromal AR signaling to induce prostate cancer cell proliferation and the possibility of the signaling in early prostate carcinogenesis. Importantly, studies are ongoing to define the events and the potential role of loss or decreased stromal AR in cancer progression and metastasis. So here you're taking a look at the working model and mechanism of fibroblast androgen receptors on the prostate cancer outcome. A good spot to hit pause. AR signaling in fibroblasts regulates the growth factors, chemoattractants, cytokines, and extracellular matrix production. AR regulates growth factors, creating a favorable environment for cancer. And with loss of AR, the local environment may drive cancer cells to metastasize elsewhere. One hypothesis is that by regulating cytokine production, AR signaling in fibroblasts influences immune responses that affect tumor cells. The declining mesenchymal AR signaling and decreased local availability of paracrine mediators could result in dedifferentiation or epithelial mesenchymal transition, or both, and a less hospitable environment for epithelial cells driving pathways for cell mobility and metastasis. The emerging significance of tumor stroma is shaping the understanding of prostate development, cancer, and metastasis. So, prostate epithelial neoplasia, a precursor lesion, a prostatic epithelial neoplasia, has been described. PIN. PIN may be more concentrated on prostate containing cancer and is noted in proximity to cancer. However, the final fate of PIN is unknown, including the possibilities of latency, invasion, and even regression. The current working model of prostate carcinogenesis suggests that repeated cycles of injury and cell death occur to the prostate's epithelium as a result of damage from inflammatory responses. There is growing evidence that chronic inflammation is involved in the regulation of cellular events in the prostate carcinogenesis, including the disruption of their immune response and regulation of the tumor microenvironment. The direct injury is hypothesized as a response to infections, autoimmune disease, circulating carcinogens or toxins, or both, from the diet or urine that has refluxed into the prostate. The resultant manifestation of this injury is focal atrophy or prostatic intraepithelial atrophy. Biologic responses cause an increase in proliferation and a massive increase in the number of epithelial cells that possess a phenotype intermediate between basal cells and mature luminal cells. In a small subset of cells, some may contain stem cells or tumor-initiating properties and telomere shortening. A subset of PIN cells may activate telomerase enzyme, causing the cells to become immortal. Molecular, genetic, and epigenetic changes can increase genetic instability and might progress to high-grade PIN and early prostate cancer formation. This model of prostate carcinogenesis needs much more research. So here you're taking a look at cellular and molecular model of early prostate neoplasia progression. Stromal environment. The prostate gland is composed of secretory luminal epithelium, basal epithelium, neuroendocrine cells, and various cell types comprising supportive tissue or stroma. Stroma, or tissue microenvironment, produces autocrine paracrine factors, as well as structural supporting molecules that help regulate normal cell behavior and organ homeostasis. Fibroblasts are the most important cells during the reconstructive phase of wound healing. The collagen and connective tissue proteins produced by fibroblasts are deposited in wounded areas after fibroblasts have entered the lesion. Thus, their presence is a signature of alterations in the stroma. Reactive tumor stroma is associated with an increased number of fibroblasts, increased capillary density, and collagen and fibrin deposition. These findings suggest that alterations in the prostate microenvironment, mediated by changes associated with aging or senescence, or both, promote epithelial responses that contribute to diseases. In animal studies, investigators have noted that the microenvironment has an increased number of cells that promote inflammation and a collapsed appearance of the smooth muscle cells with adjacent glandular stroma. Fibroblast spreading has been proposed as indicative of decreased mechanical tension because of lack of direct association of the fibroblasts with aged fragmented collagen fibrils. These alterations in mechanical tension and cell shape are suggested as determinants in altering gene expression and cellular function. These alterations in aged prostate stroma for mice and men include significant enhancement for inflammation pathways. Inflammation can induce cell stress, and stressed mesenchymal cells can secrete inflammatory mediators. However, it remains to be determined whether inflammatory infiltrates are a cause of a response to the alteration of aged stroma. Evidence supports that inflammation has a role in the pathogenesis of prostate cancer. Investigators have found that disruption of fibroblast growth factors signaling pathways leads to strongly activated and atypical stroma that preceded the development of mice in PIN. Epithelial mesenchymal transition was first described in embryonic development and is observed in a number of solid tumors. Cells that undergo EMT become more migratory and invasive and gain access to vascular vessels. Numerous studies have shown that these transition states are a consequence of tumor-stroma interactions. Investigators studying prostate cancer cells in vitro correlated EMT with increased growth, migration, and invasion. These investigators demonstrated that the microenvironment is a critical site for the transition of human prostate cancer cells from epithelial to mesenchymal structure, resulting in increased metastatic potential for bone and the adrenal gland. Prostate cancer is known to be diverse and composed of multiple genetically distinct cancer cell clones. Studies, however, indicate that most metastatic cancers arise from a single precursor cancer cell. Various research models have been proposed to understand EMT and invasion and metastasis. So, in summary, the following multifactorial general hypothesis of prostate carcinogenesis emerges from all of the observations. So, one being the androgens act as strong tumor promoters through androgen receptor mediated mechanisms to enhance the carcinogenic activity of strong endogenous DNA toxic carcinogens, including reactive estrogen metabolites and estrogen, and prostate-generated reactive oxygen species. 2. Alterations in autocrine-paracrine growth stimulating and growth inhibiting factors between the prostate tumor cells and microenvironment influence cancer pathogenesis. And 3. Possibly unknown environmental lifestyle carcinogens may contribute to prostate cancer. All of these factors are modulated by diet and genetic determinants, such as hereditary, susceptibility genes, and polymorphic genes, which encode receptors and enzymes involved in the metabolism and action of steroid hormones. The most common sites of distant metastasis are the lymph nodes, bones, lungs, liver, and adrenals. The pelvic lumbar spine, femur, thoracic spine, and ribs are the most common sites of bone metastasis. Local extension is usually posterior, although late in the disease. The tumor may involve and invade the rectum or encroach on the prostatic urethra and cause bladder outlet obstruction. The spread of cancer through blood vessels is illustrated in the following figure. So here we're taking a look at a prostate cancer. And then here you see the distribution of hematogenous metastasis from prostate cancer. So, what kind of clinical manifestations do we see? Prostatic cancer often causes no symptoms until it is far advanced. The first manifestations of disease are those of bladder outlet obstruction, slow urinary stream, hesitancy, incomplete emptying, frequency, nocturia, and dysuria. Unlike the symptoms of obstruction caused by BPH, the symptoms of obstructions caused by prostatic cancers are progressive and do not remit. Local extension of prostatic cancer can obstruct the upper urinary tract, ureters, as well. If rectal obstruction occurs, a man may experience a large bowel obstruction or difficulty in defecation. Symptoms of late disease include bone pain at sites of bone metastasis, edema of the lower extremities, enlargement of lymph nodes, enlargement of the liver, development of pathologic bone fractures, and mental confusion associated with brain metastasis. So our evaluation and treatment, therefore. Screening for prostatic cancer includes the DRE PSA blood tests and TRUS. The most significant test used in the diagnosis and management of prostate cancer is measurement of the level of the prostate-specific antigen, PSA. Again, keep in mind, PSA is elevated in both BPH and prostate cancer. DRE may detect early prostatic carcinomas, but it has low sensitivity and specificity. Cancer diagnosis is confirmed through tissue biopsy and microscopic examination of tissue. Lymphography, bone scans, MRIs, and CT scans also may be used to determine metastasis to the lymph, bone, and other adjacent tissues. Important for treatment is the accurate measure, the size of the index, tumor of the percentage Gleason's grades of differentiation. PSA screening for prostate cancer has led to a considerable controversy. A review of the evidence from the 2012 U.S. Preventive Service Task Force regarding screening for prostate cancer concluded that PSA-based screening results in small or no reduction in prostate cancer-specific mortality and is associated with harmful consequences related to subsequent evaluation and treatment, some of which may be unnecessary. However, additional evidence published since the 2012 recommendation statement suggests increased confidence in the benefits of screening. Slightly more than 1 man per 1,000 who is offered screening may avoid death from prostate cancer. There also is new evidence that 3 men per 1,000 offered screening may avoid metastatic disease. The USPSTF assigned a grade of D for men aged greater than 75 years in 2008 and for men of all ages in 2012. However, USPSTF draft recommendations in 2017 recommended against PSA-based screenings for prostate cancer only in men aged 70 years and older. Furthermore, the 2017 USPSTF draft recommendations now suggest that clinicians inform men ages 55 to 69 years about the potential benefits and detriments of PSA-based screenings for prostate cancer. Thus, making the decision about whether to be screened for prostate cancer is an individual choice for each man. Choosing to screen or not should be based on each man's values and preferences after an informed decision with the clinician. This approach may be particularly important for men who have had immediate family members diagnosed with prostate cancer. Nonetheless, convincing evidence used to formulate the 2012 U.S. Preventive Service Task Force guidelines demonstrated that the PSA test unfortunately often produces false positive results. Men who have had a false positive test are more likely to have additional testing, including 1 or more biopsies. Over a 10-year span, roughly 15 to 20% of men will have a PSA test result that triggers a biopsy, depending on the PSA threshold and testing interval used. In addition, because PSA level is organ-specific and not cancer-specific, Its measurements can increase and overlap with BPH, prostatitis, an infarct, manipulation from instrumentation, and ejaculation. Since 2012, recommendation rates of PSA screening decreased by 3 to 10% in all age groups and across most geographic regions in the US. Rates of prostate biopsy and prostate cancer incidence have declined in unison, with a shift towards tumors being a higher grade and stage upon detection. The implications of this are being considered as more data is being obtained. The annual rate by which the PSA level rises is known as a PSA velocity, or doubling time. Its calculation has been judged to be far from straightforward. More than 20 different methods for calculation have been proposed, and many of these give divergent results. Evidence clearly shows that PSA kinetics are critical for understanding prognosis in advanced or relapsed prostate cancer. However, PSA kinetics have questionable value for men with an untreated prostate. Neither PSA velocity nor doubling time has an established role in diagnosing prostate cancer or providing a prognosis for men before treatment. In fact, investigators recently evaluated guidelines on the use of PSA velocity and prostate cancer detection and found that changes in PSA levels over time is such a poor predictor of prostate cancer that it is highly likely many unnecessary biopsies have been performed. It is thus somewhat doubtful at this juncture that PSA velocity adds any additional predictive accuracy to PSA level measurements alone, or positive digital rectal examination, or both, for purposes of prostate cancer screening. For instance, a systemic review found that even when definitions are rigorously applied, PSA velocity calculation does not significantly enhance the clinical performance of PSA alone. As such, it should be noted that a recent study found that PSA levels in midlife strongly predict future lethal prostate cancers in a US cohort subjected to opportunistic screenings. Older age is the strongest risk factor for the development of prostate cancer. However, neither screening nor treatment trials show benefit in men over the age of 70. Given this knowledge, recent recommendations from a task force of the International Society of Geriatric Oncology suggest that older men should be managed according to their individual health status and not according to age. Fit elderly men should receive the same treatment as younger men on the basis of international recommendations. Across age ranges, black men and men with family history of prostate cancer have an increased risk of developing and dying of prostate cancer. Black men are approximately twice as likely to die of prostate cancer compared with other men in the US, and the reason for this disparity is unknown. Black men represent a small minority of participants in randomized clinical trials and screening, and thus no firm conclusion can be made about the balance of benefits and detriments of PSA-based screening in this population. As such, it is a questionable practice to selectively recommend PSA-based screening for Black men in the absence of data that supports a more favorable balance of risk and benefit. The ability to predict cancer rises significantly when truths is added to the annual DRE and PSA testing. Researchers are studying microRNAs as potential new biomarkers for prostate cancer. Prostate cancer is now detected in greater numbers of men at lower stages of disease and is amenable to multiple forms of efficacious treatment. However, there is a lack of conclusive data demonstrating a definitive mortality benefit from this early diagnosis and treatment of prostate cancer. This is likely because of the treatment of a large proportion of indolent cancers that would have had little adverse effect on health or lifespan if left untreated. So, the following box here discusses the rethinking of screening for prostate cancer and breast cancer. Because of this overtreatment phenomenon, activity surveillance with delayed intervention is gaining traction as a viable management approach in contemporary practice. The ability to distinguish clinically insignificant cancers from those with a high risk of progression or lethality, or both, is critical to the appropriate selection of surveillance protocols versus immediate intervention. Mounting evidence also suggests that intermittent PSA testing may decrease the cost of detriments of screening while preserving the benefits of annual testing. The most important observation for pathologists to make to facilitate cure of any man with prostate cancer is that of accurate measuring the size of the index tumor and determining the Gleason score. So, the following box here shows the prostate-specific antigen-based screening for prostate cancer. Again, a good spot to hit pause if you're unfamiliar. I'll try to set it so that it makes sense to pause at certain sections here. Treatment of prostatic cancers depends on the stage of the neoplasm, the anticipated effects of treatment, and the age, general health, and life expectancy of the individuals. Options include 1. No treatment, 2. Surgical treatment such as a total prostatectomy, the transurethral resection of the prostate or a TURP procedure, and cryotherapy. 3. Non-surgical treatments such as radiation therapy, hormone therapy, and chemotherapy. 4. The wait and see. And 5. Any combination of those. In addition, new approaches are using immunotherapy. Palliative treatment is aimed at relieving urinary bladder outlet or colon obstruction, spinal cord compression, and pain. Prognosis and survival rates have improved steadily since the 1960s. According to the most recent data, 10 to 15-year relative survival rates are 98% and 95% respectively. A study examining a 10-year outcome after monitoring, surgery, and radiotherapy for localized prostate cancer found that at a median of 10 years, prostate cancer-specific mortality was low regardless of the treatment assigned, with no significant differences among treatments. Surgery and radiotherapy were associated with lower incidences of disease progression and metastasis than was active monitoring. Treatment for prostate cancers may lead to loss of urinary control, which may or may not return to normal after several weeks or months. Stress incontinence can occur after surgery, and mild urge incontinence can occur after radiation therapy. Prostate cancer and its treatment can affect sexual functioning. Sensation of orgasm is not usually affected, but smaller amounts of ejaculate will be produced, or men may experience a dry ejaculate because of retrograde ejaculation. So that brings us to sexual dysfunction. In men, the normal sexual response involves three processes: erection, emission, and ejaculation. Sexual dysfunction is the impairment of any of all of these processes. Impairment can be caused by a number of physiologic and psychologic factors. Until the late 1970s, most cases of male sexual dysfunction were thought to be psychogenic. Studies of this problem indicate that in men older than 40 years, organic factors are involved in more than 50% of cases. The causes of organic sexual dysfunction include 1. Vascular, endocrine, and neurologic disorders, 2. Chronic disease, including renal failure and diabetes, 3. Penile disease and penile trauma, and 4. Iatrogenic factors, such as the surgery and pharmacologic therapies. Most of these disorders cause erectile dysfunction. Leading us to the pathophysiology and clinical manifestations. Vascular disorders can prevent erection. Some arterial diseases diminish or interrupt circulation to the penis. This prevents engorgement of erectile tissue in the corpora cavernosa and corpus spongiosum. Rarely, excessive venous drainage of the corpora cavernosa prevents erection. Endocrine disorders that reduce testosterone production affect sexual function and libido. The reduction may be caused by inadequate secretion of the gonadotropins, caused by pituitary dysfunction or hyperprolactinemia. Feminizing tumors and estrogen therapy reduce relative levels of testosterone. Testicular atrophy from any cause also decreases testosterone levels and contributes to sexual dysfunction. Neurologic disorders. Neuro- Neurologic disorders can interfere with the important sympathetic, parasympathetic, and CNS mechanisms required for erection, emission, and ejaculation. They include spinal cord injury or tumor, multiple sclerosis, and disorders that cause peripheral neuropathies, such as diabetes and chronic renal failure. Spinal cord injuries or tumors can alter one or more components of the sexual response, depending on the location of the lesion. For example, in most men with upper motor neuron lesions, reflexogenic erection is possible, but emission and ejaculation are not possible. Lesions affecting the lower motor neurons usually prevent erection. In roughly 40% of such cases, emission and ejaculation are prevented. Many chronic diseases are associated with sexual dysfunction. In some conditions, the sexual dysfunction has a specific physiologic cause. Diabetes, for example, causes peripheral vascular and neurologic pathology that can lead to erectile dysfunction. Impotence occurs in about 50% of men undergoing dialysis because of decreased testosterone levels, autonomic neuropathy, accelerated vascular disease, multiple medications, worsening of primary disease, and psychologic stress. Potency may be restored by successful renal transplantation, except in bilateral transplantation if arterial flow is diminished or interrupted. Cirrhosis of the liver, scleroderma, chronic debilitation, and cachexia also are known to cause impotence. Emotional and psychological response to chronic illness, such as anxiety, depression, and loss of self-esteem, can affect sexual functioning. In other chronic conditions, sexual dysfunction is associated with low energy levels and loss of libido. The pathophysiologic mechanisms responsible for such changes are not known. Priapism causes fibrosis of trabeculae within the corpora cavernosa, making erection difficult. The penile curvature caused by Peyronie disease does not make erection impossible, but it may make it extremely painful and intercourse impossible. Penile trauma can damage the erectile tissue, disrupt the posterior urethra, and disrupt the pudendal arteries or nerves. Iatrogenetic factors, including drugs and surgery, have a significant effect on erectile dysfunction. The following surgical procedures carry the risk of erectile dysfunction: radical pelvic surgery, radical prostatectomy, transurethral, suprapubic, or simple retropubic prostatectomy, and aortoiliac surgery. Erectile dysfunction is caused by the severing of small nerve branches that are essential for erection. Aortoiliac surgery, retroperitoneal lymphadenectomy, and sympathectomy cause the loss of ejaculation capacity in some individuals. A few pharmacologic agents enhance the sexual response, but most have the opposite effect. Men who are taking antihypertensive, antidepressants, antihistamines, antispasmodics, sedatives, or tranquilizers, barbiturates, diuretics, sex hormone preparations, narcotics, and psychoactive drugs may all experience some degree of sexual dysfunction. Drug-induced sexual dysfunction consists of decreased desire, decreased erectile ability, or decreased ejaculatory ability. Ethyl alcohol may induce alcoholic neuropathy or increased levels of estrogen because of hepatic dysfunction. Marijuana depresses testosterone levels, and cigarette smoking contributes to a vasoconstriction and venous leakage. A number of pharmacologic agents also diminish the quality and quantity of sperm. A few may cause priapism. Drugs can assist in maintaining an erection, however. So are evaluation and treatment. Evaluation of sexual dysfunction includes a physical exam with particular attention to the genitalia, prostate, and nervous system, and basic lab tests to identify the presence of endocrinopathies, or other underlying disorders that can cause the dysfunction. If no physiologic cause is found and the condition does not improve, with psychotherapy, the man is referred to further investigation of organic causes. Psychologic evaluation is indicated for younger men with a sudden onset of sexual dysfunction, or men of any age, who are able to achieve but not maintain an erection. Sophisticated diagnostic techniques can be used to assess penile blood flow, erectile tissue anatomy, nervous system function, and occurrence of erection or emission during sleep. Penile blood flow is measured by Doppler techniques and penile arteriography. Corpus cavernosography, in which contrast material is ejected into the corpora cavernosa, provides anatomic information about the erectile tissue of the penis. Neuropathic causes of sexual dysfunction are evaluated by measuring the speed of the bulbocavernous reflex. Nocturnal penile tumescence monitoring measures the frequency of nocturnal erections. Depending on the equipment used, this information may be correlated with rapid eye movement or non-REM sleep. Treatments for organic sexual dysfunction include medical and surgical interventions. Non-surgical interventions include correction of underlying disorders, particularly drug-induced dysfunction and endocrinopathy-related dysfunctions. Use of vasodilators and cessation of smoking can benefit individuals with vasculogenic erectile dysfunction. Surgical interventions include penile implants, penile revascularization, and correction of other anatomic defects contributing to sexual dysfunction. The impairment of sperm production and its quality. Spermatogenesis requires adequate secretion of FSH and LH by the pituitary, sufficient secretion of testosterone by the Leydig cells, sufficient function of the Sertoli cells, including secretion of androgen-binding protein, growth factors, inhibin B, and a number of other important peptides, and adequate spermatogonia. The Leydig cells are located in the testicular interstitium between the tubules, and the Sertoli cells and spermatogonia are located within the seminiferous tubules. The Sertoli cells extend from the basement membrane to the lumen, display tight junctions between adjacent cells, and form blood-testis barriers. Inadequate secretion of gonadotropins may be caused by hypothyroidism, hyperandrenocortisolism, hyperprolactinemia, or hypogonadotropic hypogonadism. In these situations, gonadotropin levels are low because of feedback inhibition or idiopathic hyposecretion. In the absence of adequate gonadotropin levels, the Leydig cells are not stimulated to secrete testosterone, and sperm maturation is not promoted in the Sertoli cells. Spermatogenesis depends not only on the appropriate stimulation by the gonadotropins, but also on an appropriate response by the testes. Defects in testicular response to the gonadotropins results in decreased secretion of testosterone and inhibin B. And, as a result of normal feedback mechanisms, high levels of circulating gonadotropins. In the absence of adequate testosterone level, spermatogenesis is impaired. Newer research demonstrates the significance of inhibin B as an important marker of the competence of Sertoli cells and spermatogenesis. Inhibin B is strongly correlated with the severity of spermatogenetic effects. A positive correlation exists between serum inhibin B and sperm concentration and testicular volume. and lower levels have been associated with azoospermia, testicular disorders, and infertility. Impaired spermatogenesis also can be caused by genetic disorders, myotonic dystrophy, or testicular trauma. Other conditions associated with impaired spermatogenesis, including systemic illness such as renal failure, hepatic disease, or sickle cell disease, exposure to gonadotoxins such as chemotherapy or radiation, varicocele, and cryptorchidism. Fertility is adversely affected if spermatogenesis is normal, but the sperm are chromosomally and morphologically abnormal, or are produced in insufficient quantities. Chromosomal abnormalities are caused by genetic factors and by external variables, such as exposure to radiation or toxic substances. Ongoing research using small ribonucleic acids is elucidating the molecular mechanisms regulating spermatogenesis. A sperm count of 20 million sperm per milliliter of semen has been suggested as a minimum concentration required for fertility. Average fertile men have 50 to 100 million sperm per milliliter. Sperm motility is another important variable affecting fertility. Motility appears to be affected by the sperm's chemical environment, that is, characteristics of semen. Prostatic dysfunction, excessive semen viscosity, presence of drugs or toxins in the semen, and presence of anti-sperm antibodies are associated with impaired sperm motility. Roughly 3 to 7% of infertile males have anti-sperm antibodies in their semen. Anti-sperm antibodies may develop as a result of epididymitis or other inflammation of the genitourinary tract, testicular injury or torsion, a previous vasectomy or biopsy, and cryptorchidism. Anti-sperm antibodies may be cytotoxic antibodies which attack sperm and reduce their number in the semen, and sperm immobilizing antibodies, which impair sperm motility and reduce their ability to traverse the endocervical canal. Intrinsic biologic factors leading to the production of anti-sperm antibodies seem to play a greater role than extrinsic factors. The exact mechanism remains unclear. The male factor contributes to the cause of up to 50% of cases of infertility. As understanding of the male factor is infertility increases, evaluation becomes more complex and essential to appropriate treatment. Treatment for impaired spermatogenesis involves correction of underlying disorders and avoidance of radiation or toxins, androgens, human gonadotropins, and anti-estrogens may enhance spermatogenesis. Semen can be modified to improve sperm motility. If conception is desired, the semen is obtained by masturbation, after which it can be diluted, concentrated, or washed to remove anti-sperm antibodies. These alterations are followed by artificial insemination. So, this following box here talks about the evaluation of male partner of infertile couples. Disorders of the male breast. Gynecomastia. Gynecomastia is the overdevelopment of breast tissue in a male. Gynecomastia accounts for roughly 85% of all masses that develop in the male breast and affects 32 to 40% of male population. If only one breast is involved, it is typically the left. Incidence is greatest among adolescents and men older than the age of 50. Gynecomastia results from hormonal alterations which may be idiopathic or caused by systemic disorders, drugs, and neoplasms. It usually involves an imbalance of the estrogen-testosterone ratio, which can be altered in one of two ways. First, estrogen levels may be excessively high, although testosterone levels are normal, as in drug-induced and tumor-induced cases of hyperestrogenism. Second, testosterone levels may be extremely low, although estrogen levels are normal, as is the case of hypergonadism. Gynecomastia also can be caused by alterations in breast tissue responsiveness to hormonal stimulation. Breast tissue may have increased responsiveness to estrogen or decreased responsiveness to androgen. Alterations responsiveness may cause many cases of idiopathic gynecomastia. Besides puberty and aging, estrogen-testosterone imbalances are associated with hypogonadism, Klinefelter syndrome, and testicular neoplasms. Hormone-induced gynecomastia is usually bilateral. Pubertal gynecomastia is a self-limiting phenomenon that usually disappears within 4 to 6 months. Senescent gynecomastia usually regresses spontaneously within 6 to 12 months. Systemic disorders associated with gynecomastia include obesity, cirrhosis of the liver, infectious hepatitis, chronic renal failure, chronic obstructive lung disease, hyperthyroidism, tuberculosis, and chronic malnutrition. It may be that these disorders ultimately alter the estrogen-testosterone ratio, initiating gynecomastia. Gynecomastia is often seen in men receiving estrogen therapy in preparation for either a sex change operation or for prostatic carcinoma. Other drugs that can cause gynecomastia include digitalis, cimetidine, spironolactone, resorpine, thiazide, isoniazid, ergotamine, tricyclic antidepressants, amphetamines, vincristine, and busulfan. Recent data reveals that the use of a 5-alpha reductase inhibitor for BPH increases the risk of a gynecomastia. Malignancies of the testes, adrenals, or liver can cause gynecomastia if they alter the estrogen-testosterone ratio. Pituitary adenomas and lung cancers also are associated with gynecomastia. So its pathophysiology, the breast enlargement consists of a hyperplastic stroma and ductal tissue. Hyperplasia is a firm palpable mass, at least 2 centimeters in diameter, located beneath the areola. So its evaluation. The diagnosis of gynecomastia is based on physical examination. Identification and treatment of the cause are likely to be followed by the resolution of the gynecomastia. The man should be taught to perform breast self-examination and is examined at 6 and 12-month intervals if the gynecomastia persists. All unilateral breast enlargement in men warrants an evaluation for malignancy. Workup includes a fine needle aspiration, cytology, a mammography, ultrasound, and biopsy. Which brings us to cancer, the last section of this chapter. Male breast cancer is rare. Male breast cancer accounts for 1% of all male cancers and less than 1% of all breast cancers. Global incidence rates were generally less than 1 per 100,000 in men, years in contrast to much higher rates in females. The highest incidence rate for male breast cancer is in Israel with 1.24 per 100,000, and the lowest incidence rates for males and females were observed in Thailand. The mean age of diagnosis is between 60 and 70 years of age. Although men of all ages can be affected, risk factors for male breast cancer include radiation exposure, estrogen administration, and diseases associated with hyperestrogenism, such as cirrhosis or Klinefelter syndrome. An increased incidence is reported in men with a number of female relatives with breast cancer. There is an increased incidence in families with BRCA2 mutations. Similar to female breast cancer, infiltrating ductal cancer is the most common tumor type. Intraductal cancer, inflammatory carcinoma, and Paget's disease of the nipple have been diagnosed in men. Patterns of metastasis are similar to those in females. The diagnosis of cancer is confirmed by biopsy, but because of delays in seeking treatment, male breast cancer may be advanced at time of diagnosis. Main treatments include chemotherapy and surgery. And that concludes our chapter here today. I thank you as always for listening and watching, and I'll see you all next time. Till then, thank you and have a wonderful day.